Good evening, everyone, and welcome to the role of psychology and general practitioners in assessing gender affirming medical care webinar. My name's Helene, and I'm the Workforce Development Officer here at Westvic PHN, and working alongside of me is Jade, and she also works here. We do the back end of all the webinars. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm on Wadawurrung country tonight. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations people and organisations. Just a little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel. Jade will have that up there. We will put the link to access our recorded webinar events into the chat. Please see our upcoming events that are on the screen now. You can register any of these events through our website, and that link will also be in the chat. Please make note of the Westvic health pathways relating to this topic that Jade has on the screen at the moment. Now, if you've entered this webinar not displaying your accurate first and last name, could you just type your full name into the chat box? Only the admin will see this, and it's just to ensure that we issue you with a certificate of attendance. For this evening webinar, all participants will remain on mute, and if you have any questions, could you type them in the question and answer box, and they will be addressed throughout the webinar. Your feedback is important, so if you can take the time to complete the event survey, there's a link in the chat to that. So let's get right along to it. And our presenters for this evening are Dr. Nick Brayshaw, General Practitioner, and Dr. David Demmer, Psychologist. So I'll hand straight over to Nick to start the presentation. Thanks, Nick.
Thank you, Helene. Good evening, everyone, and thanks for joining us. I'm just going to share my screen, if I can get that up. So I'm Nick Brayshaw, pronouns he, him, GP at Cardinia Health. I'd like to echo Helene's acknowledgement of country, and I'd also like to acknowledge any trans, gender diverse or non-binary people who might have tuned in tonight. Whilst we don't have any trans presenters tonight, these guidelines and the information I'm going to talk about have been very much informed and developed with lived experience input. Plus, everyone, please feel free to add comments or feedback in the Q&A segment. One of the strengths of our Australian medical system is the centrality of a strong primary care sector, and general practice provides and coordinates whole person, patient-centred, continuous, multidisciplinary medical care, which is precisely the best model, best practice model in gender affirming care. Not to mention that trans people need to be able to access general medical care, just like everyone else, but with the confidence of inclusion and safety. I want to highlight that general practice is often the first place that people reach out to, and their first point of contact is often with our reception staff. So their role of our receptionists and front of desk is, and their interaction and their role is critical. GPs are really well placed to initiate and monitor gender affirming hormone therapy for adults, and which is typically best provided within a primary care led multidisciplinary team tailored to the patient's needs. The Australian Professional Association for Trans Health, AusPath, is Australia's peak body for professionals involved in the health and wellbeing of all trans people, binary and non-binary. And the AusPath have developed and published the Australian Informed Consent Standards of Care for gender affirming hormone therapy, which I'm going to talk to briefly tonight. Dr. Clara Tuckming-Sue, former director of AusPath, has been a GP in Canberra since 1993 and working with trans people, has been one of the most rewarding experiences of my life, particularly as one of the few trans doctors in Australia. These guidelines have been developed and reviewed by the full AusPath board and every subcommittee. If you like to go afterwards to the AusPath website, you'll find reference to these and a number of other authoritative guidelines that have been published. I want to particularly make mention of the World Professional Association for Trans Health Standards of Care version 8, which were published 18 months ago, and really align or support the AusPath Australian guidelines. Dr. Fiona Bishop, another former president of AusPath, is GP in Brisbane, been seeing trans people in her practice for 20 years, says often by the time they come to me, they've been waiting for months or years because their own GP wasn't confident or didn't understand. Over the last few years, AusPath has supported hundreds of GP colleagues across Australia to deliver the life-saving intervention of gender-affirming hormones. This standard of care will ensure that all doctors have access to the right localised information so they can feel competent and confident with their trans patients. And so this is around the AusPath standards of care is around what's referred to as the informed consent model, which really places an emphasis on self-determination, patient-centred care, and mental health support as needed. Unfortunately, mental health challenges are very prevalent amongst transgender diverse population because of the stigma and discrimination and ways in which the challenges they often face in our society. The model runs through a model of having a series of preliminary visits during which the GP can confirm the history of gender incongruence, which is usually pretty plain on discussion with the patient. Take a comprehensive medical and family history, largely not to check for any issues that might impact on our prescribing. There's rarely true contraindications, but there may be considerations to take into account. A mental health assessment and offer referrals for counselling and for peer support. It's really important to explore the patient's ideas and concerns and knowledge and expectations and make sure that we understand their individual goals. To discuss the expected changes and timelines from hormone use, and to discuss potential complications and side effects. A basic examination doesn't need to be extensive or invasive. Baseline bloods, discussion around fertility preservation options, offer referral for sperm cryopreservation or potentially for egg storage for birth-assigned females. And finally, to assess and document the person's capacity to provide informed consent. So I think there's nothing there which is not fairly familiar in what GPs do every day, perhaps in different contexts, but nonetheless, it's not a big leap. GPs can initiate and monitor hormone therapy for adults. It's, as we said, typically best done within a multidisciplinary team tailored to the patient's needs, although not everyone needs or wishes for involvement of non-GP specialists. Many people do benefit from engaging with a psychologist, particularly if experiencing significant depression or anxiety, or navigating complex family relationships. Surgeons require a psychiatrist or clinical psychologist assessment prior to a gender-affirming surgeries, and David will talk about that a bit. And there's a whole range of other medical and allied health disciplines who may be valuable members of an individual's team. Another AusPath director, Teddy Cook, emphasises the importance that these standards of care were produced through collaboration and consensus building for members and for the broader medical community, and most importantly, for trans people seeking hormonal affirmation. So in summary, for adults, all doctors can be a gender-affirming doctor. Gender-affirming medicine is part of general medical care within the primary healthcare system. All people should be offered trans-affirming and culturally safe support throughout the process of exploring or affirming their gender. And this may include peer support, connection to community groups, counselling, social work, psychology, psychiatry. Clinicians who are new to hormone prescribing may find it helpful to access the resources I've mentioned, even to join AusPath or attend their annual training days. In Geelong, we have a special interest group, a clinical community of practice that meets monthly. People are very welcome to contact that group and to join. And there's also a wonderful resource I'd like to point you towards in Trans Hub website, which has a comprehensive range of good quality information for clinicians, for people with living experience, for allies, for families, all the different perspectives, and covering all facets of gender affirmation. So a final quote from Maggie Smith, who emphasised that gender-affirming medical care is so much more than hormones. It's about building trust and offering reassurance, listening to the patient and believing them, facilitating access to the community and advocating where necessary. The relationship between the patient and gender-affirming clinician is profound. In many cases, it's life-saving. And that's really been emphasised again by research in Melbourne, published late last year, where showing that people who were able to access gender-affirming hormones in a timely fashion had markedly improved mental health measures and markedly reduced suicidality compared to a control group who were on the standard waiting list of 6 months or more. I would like to point to some important resources available for peer support, for counselling, for advocacy and case management, and for professional development. Queer Space in Melbourne, and under the umbrella of Queer Space in Geelong, we now have the fabulous Q Hub, which opened just in recent months, where there's a number of peer support workers with lived experience providing support and counselling and education and a range of services for young people in our region. And there's also a Q Hub in Ballarat. So that's where I was going to cover in regards to considerations for adults. We'll come back in a few minutes to David Demmer, who's going to talk about the role of psychology in gender-affirming medical care. But I'll just pivot a moment to talking about there's particular considerations for children and minors under the age of 18 who can only access gender-affirming medical treatment with the consent from both of their parents, which is a very important consideration. This medical practitioners are unable to initiate blockers or gender-affirming hormones without first ascertaining and establishing the consent of the child's parents or legal guardians. And if there's a dispute around that, it requires an application to the family court. Just to highlight the question in regard to puberty blockers, I would mention that I don't know any GPs who prescribe puberty blockers. They're only available in Victoria through the Royal Children's Hospital Gender Service, a highly specialised service, and they need to be commenced at the very onset of puberty in order, for those people who wish for that, in order to suspend progression of puberty whilst buying time for the young person to develop the maturity and more exploration and more knowledge to be able to reach an age and a maturity where they are gillick competent and able to make an informed choice. And puberty blockers, of course, if the person ultimately chooses not to pursue affirming their non-birth assigned gender, puberty blockers can be ceased and their birth assigned puberty will then begin. The ruling from the re-imaging case in 2020, again emphasising that there has to be to commence hormones, there has to be no dispute between the parents, the medical practitioner, and the young person themselves in regards to the person's gillick competence of an adolescent, the diagnosis, of course, of gender dysphoria, and the proposed treatment for gender dysphoria or gender incongruence might be better terminology. Unfortunately, in many cases where parents or carers or guardians don't consent, it may result in a trans person simply having to wait until they reach the age of 18 in order to access hormones. Or what unfortunately is prone to happen is people may then access hormones themselves outside of medical care, outside of medical oversight. These Australian standards of care for children and adolescents were first published in 2017 by the team from the Royal Children's Hospital and lauded around the world as groundbreaking authoritative guidelines, subject to a very complimentary editorial in The Lancet. In general practice, gender-affirming medical care for children and minors is often generally more of a supportive role. Important, that is, as people often await other services, and providing that support to young people and parents is really important, but that's often the key part of what general practice can provide. Early referral to the Royal Children's Hospital Gender Service if pre-pubertal, if the person's pre-pubertal, and if they require consideration for puberty blockers. And GPs may be in a position to be coordinating and initiating prescription of gender-affirming hormones for gillick competent 16, 17-year-olds, as we've discussed. The Australian RCH guidelines were reviewed and the version 1.4 published late last year. And I just want to emphasise a few things from there. They recognise the key that many GPs play a central role in the provision and coordination of gender-affirming care, and that GPs are well equipped to provide this role. And communication between GP and members of a multidisciplinary team allows for optimal care. Just a couple of specifics, drilling down on a couple of details from these new revised guidelines, which now support that GPs with sufficient expertise and skill in initiating and monitoring hormone therapy can consider initiating and optimising hormone therapy for suitable gillick competent minors. This would typically be within a primary care lead multidisciplinary team tailored to the patient's needs and what services are available, which may include non-GP specialists such as paediatricians, adolescent physicians or endocrinologists, sexual health physicians, fertility specialists, nurse practitioners, dietitians, speech therapists, social workers or others. And many young people, many young gender diverse people benefit from mental health support, and GPs should discuss this with patients and offer referrals to psychologists or psychiatrists or other mental health professionals if and as required. The appropriate members of a collaborative team should be directed to the specific needs of the young person in front of us. In addition to that, point 11A, 11B recognises fully that in some circumstances, the GP or prescribing clinician might not feel confident to assess the appropriateness of gender-affirming medical treatments or assess a patient's readiness to commence these treatments by themselves and may be uncertain about the patient's ability to provide informed consent. So in these circumstances, a referral should be made to a qualified mental health professional with experience in providing gender-affirming care so that the patient's supported to find the right pathway of treatment for their needs and the mental health professional can support a patient's exploration of their identity, assess their decision-making capacity and help address any mental health concerns or complexities. So in summary, in relation to young people, GPs would take a detailed medical and adolescent psychosocial history, understand and explore the young person's goals for their gender care, connect the person to services and resources, including peer and parent support groups, referring to a mental health clinician where appropriate, provide written information on social and medical interventions, the basic general physical examinations we've mentioned and baseline investigations, and establish informed consent for medical intervention. So discuss the risks and benefits of hormone treatment with the young person and their parents. Provide or refer for fertility preservation counselling or intervention. Assessment of a young person's capacity to provide informed consent, liaise with mental health clinician involved in the young person's care, and document these discussions with consent forms. And finally, legal issues, consider legal issues in relation to prescribing hormone treatment and in relation to changing documents such as Medicare cards and birth certificates. So, final slide is this telephone advice line for GPs operated by the Royal Children's Hospital Gender Service, a wonderful support service, knowledgeable team of people there, accessible on this number during working hours. And I just also want to flag that the RCH Gender Service have run several education days in recent years, and there is another one calendared for later this month. If anybody's interested in attending, maybe contact Jade and Helene at the PHN afterwards, and we can provide details of how to access the education day at RCH. I think the 29th or 30th of May, that's coming up. So thanks for listening to my component of tonight's talk. That's all from me. I shall pass over to David.
Thank you, Nick. I'll just share my screen, bear with me. Thank you very much. So, good evening, everyone. Thank you for having me along. My name's Dr. Dave Demmer. I use he, him pronouns. I'm a clinical psychologist, and I'll be talking tonight a bit of I guess, a crash course on the role of psychology in accessing gender-affirming medical care, which is kind of the other side of the coin to what Nick has been talking about in terms of the informed consent model. So I'm the director of Q Psychology, which is a private psychology practice with clinics in Geelong, St Kilda and Carlton, and I lead a really wonderful team of mostly queer and mostly neurodivergent mental health practitioners and psychologists doing some wonderful work in this space. So I think in order to, I guess, set the scene a little bit around the importance of gender affirming care and gender affirming medical care, as a psychologist, I'm always drawn to these extraordinarily high rates of mental health difficulties for our transgender, diverse, non-binary populations. Everything from our high prevalence disorders like depression and anxiety, right through to our low prevalence disorders like bipolar and OCD, are just drastically higher for trans populations, and the prevalence of any psychological disorder for trans people is 2.5 times higher than the general population. So I'm sure we can all understand how concerning and confronting that is. And when we look at the pointier end of mental health, when we're talking suicide, again, much higher prevalence rates here, both for suicidal ideation and suicide attempts. So, transgender, diverse, non-binary populations are 10 times more likely to attempt to take their life at some point in their journey. Just extraordinarily high rates. I guess that kind of leads me to, as a psychologist, what can we do about that? And I think, certainly one of the best answers we have is to be able to provide gender affirming care. I'm going to talk a little bit about, from a psychological perspective, what we see gender affirming care as. But I think if we can even just take this one sentence, which comes directly from the WPATH Standards of Care, version 7, which says, a transgender identity is a matter of diversity, not pathology. And if we can keep that approach or that ethos or that sentence in mind, we'll go a long way, I think, to practicing as gender affirming healthcare practitioners. So gender affirming care more broadly really encompasses a range of social, psychological, behavioral and medical interventions that support and affirm an individual's gender identity. And it's an approach to care that's delivered with both cultural and clinical competency, and which is informed all the way along by the lived experience of trans populations. And includes, first and foremost, supporting gender affirmation in all of its many forms, be that social affirmation, legal affirmation, medical affirmation through gender affirming medical and surgical treatments. I think that there's a really unfortunate perception out there for some people that gender affirming care, and in particular gender affirming medical care, is a pathway rather than an approach. Certainly people who are not supportive of medical affirmation for trans populations can often hold this idea that it is a sequence of things that happen, and as a healthcare system, as medical practitioners, as allied health practitioners, we force people down this pathway, particularly towards medical interventions to affirm their gender. And gender affirming care is not a pathway, it's an approach, it's a way that we can be with our clients, that shows them respect, that shows them that we believe them, and that we're led by them in their journey, as opposed to it being a direction or a pathway that we're pushing people down. As I said, it's about being patient-led and creating safe environments through inclusivity, through appropriate language and terminology. And that's not just within our clinic room, but it's within kind of our broader clinic as a whole. It's within our healthcare system. It's from the very kind of the entire journey of our clients and patients, making sure that their entire journey with us is safe. It's about understanding the healthcare landscape, the services, and the quite significant barriers to service for trans populations. Understanding the informed consent model versus the assessment model in accessing gender-affirming medical care, and obviously that's what I'm going to be talking about, the latter. And considering trauma-informed care as kind of a non-negotiable in our approach with our trans populations. I won't go too much into what the research says around the outcomes of gender-affirming care for trans populations, but you can rest assured that it has really positive outcomes, and that's not just medical affirmation, but social affirmation, being in the hands of gender-affirming healthcare professionals. The research all points to it being really powerful for positive outcomes from a psychological perspective. So accessing gender-affirming medical care, as Nick has spoken about, he's talked quite thoroughly about what's called the informed consent model or affirmation enablement. And as he said, it really kind of implies capacity. It infers that an individual has kind of capacity to consent. It supports their body autonomy. It gives them agency in their medical decisions and in their affirmation decisions. On the flip side of this, on the other side of the coin, the other avenue or the other route for accessing gender-affirming medical care is what we tend to term the WPATH assessment model. And that's where the role of psychology does come in. So the WPATH assessment, I'm hoping to kind of demystify it and hopefully give you all a bit of an understanding of when you do refer someone for a WPATH assessment, what it is that they, from a gender-affirming approach, would experience in that process. So it is technically a formal assessment based on the WPATH standards of care and the recommendations that are included in those, and also other guidelines where appropriate. So for example, if the assessment is for someone under the age of 18, then of course the Royal Children's Hospital guidelines that Nick introduced us to just before would be incredibly relevant. It's conducted by a qualified clinician, usually a mental health clinician. And it's really set to, or the purpose of it is really to explore one's readiness for medical affirmation. So a bit of whens and whats. As Nick was talking about, there has been the update to the Royal Children's Hospital standards of care, where they certainly do support and encourage, under the circumstances of guilt competence, that a young person is supported with a more informed consent process to access gender-affirming hormones. Now, in the private sector, there are still, I guess, a lot of WPATH assessments under 18 that are still occurring for young people who want to access gender-affirming hormones. And this is usually based around supporting the treating team to be sure that the young person is guilt competent or a mature minor. If someone is over the age of 18 and they're looking to access gender-affirming hormones, then typically, and rightly so, the informed consent model is absolutely appropriate and indicated in those instances. There are some cases where people over the age of 18 do still come for WPATH assessment prior to accessing gender-affirming hormones. And it's usually in the context of either the individual kind of requesting it, wanting this extra level of support and exploration before they make that decision for themselves, or when there is, I guess, significant complexity to somebody's life experience. Maybe there's significant mental health challenges. Maybe there are questions around their capacity to consent for whatever reason. But as I said, it's quite rare these days. As Nick mentioned, if someone's over the age of 18 seeking gender-affirming surgery, then surgeons will typically require a WPATH assessment. Surgeons do typically require these from a psychiatrist or a clinically endorsed psychologist, as opposed to a generally endorsed psychologist or a psychologist with a different endorsement, such as forensic or health. So when kind of making those referrals, it's important that that's either checked with the surgeon that they do require a clinical psychologist, or simply assumed and a referral is made to a clinical psychologist rather than a general psychologist. In order to, I guess, demystify what a WPATH assessment is, I just want to talk through a little bit. And this is certainly what I orientate clients to when they first come for an assessment. I like to break down the barriers and speak to what the process is, as opposed to maybe some of the perceptions of what a WPATH assessment is that might exist out there in the community. So essentially, it's a process of supporting someone with their understanding and clarifications of their affirmation goals, and exploring how ready they are for those goals. And I think it really boils down to these two words. Are we informed, and are we making our medical decisions from an informed place, like we would want to and expect with all medical decisions, not necessarily just gender affirming medicine? And are we safe? Have we is this a good enough time, or enough of our ducks in a row that we're going to get the positive outcomes that we would experience by engaging in this step in medical affirmation? So informed and safe are these two words that kind of continually resonate or run around in my head through the assessment process. It is technically a assessment of capacity. Now, that's one part that always sits really uncomfortably with me, because if we look at the legislation around anyone over the age of 18, they automatically are granted capacity to consent to their own medical treatments, unless, of course, there is some question marks or concerns about their capacity to consent. So from my perspective, when an adult comes for a WPATH assessment, they should automatically be granted capacity. Now, if as we go along in the process, if there some question marks or concerns that come up, then rightly so, we obviously would want to explore that. But there's no, there's no need to kind of prove capacity. It should automatically be granted by the mental health professional if they're over 18. There's also a process of extra support and maybe exploring some further psychosocial considerations of affirmation as well. Sometimes, people are right at the beginning of their gender journey, and that when they're accessing gender affirming hormones in particular. And it might be that a little bit of extra support and consideration and exploration about their social journey as well, particularly in the context of physiological changes and gender expression changes that will occur as a function of accessing gender affirming hormones. The assessment's also about providing and planning for supports where they're needed. That's particularly relevant for surgery and post-surgery as well. So just important as what a WPATH assessment is what a WPATH assessment is not. And I think it's really important that we make this clear, that a WPATH assessment is not an assessment of an individual's gender or gender identity. Someone's gender identity is not a pathology, it's not a disorder, doesn't need assessment, doesn't need treatment. And I can get quite dismayed when I hear about when WPATH assessments are called gender assessments, because it's then kind of implied that we're assessing someone's gender, but we're not. It's also not a process of an individual having to come in to prove their trans identity or to prove stable and positive, that they're a perfect picture of mental health. And it's also not necessarily a decision on whether they should proceed with the treatment. It's not our role to decide what someone should do with their body. It's about ensuring that they are making the decision about their body from an informed and safe place. So these are the specific criteria. These are the adult criteria. There's some differences for people under the age of 18. These come directly from the WPATH standards of care. I won't go into them specifically for the sake of time, but you can certainly access these. They're in the appendices of the standards of care version 8 towards the end. They're pretty clear. They make it pretty clear what we're meant to assess. And what we've got here is, I guess that what I will say is there is no set assessment process. There are no specific guidelines that says this is exactly how you need to do it, and this is what session 1 should have and session 2 should have, and et cetera, et cetera. But over several years of administering many of these assessments, I'd say hundreds by now, we're publishing research in this area as well. These are kind of the main domains that we've kind of found are most important. So of course we want to understand someone's gender journey. criteria from the WPAS standards of care that talks about that there is kind of sustained and marked gender incongruence. So that doesn't necessarily mean that somebody has been affirmed in a specific gender identity and that that's been stable for a specific amount of time. It's more about the incongruence over time, and it may not actually be known incongruence. It may not be, you know, it's not uncommon for individuals to talk about kind of coming to a realization of their gender identity a little bit later in their journey, and in hindsight, they say, "Oh, now a lot of stuff from, you know, puberty, the distress in puberty makes sense, and why I didn't want to connect with this gender, these genders at school, etc." So it's about kind of a sustained nature of the incongruence rather than saying that someone has to have been a certain gender identity for an extended amount of time. And also understanding what their social journey has been as well. Obviously, we go through a fairly extensive biopsychosocial assessment. So this is where we're looking at background and functioning and understanding their current and past mental health. The standards of care, one of the best changes that happened in September 2022 with the change from standards of care 7 to standards of care 8, in my opinion, was that the criteria around mental health changed for these assessments. So in standards of care 7, it spoke about mental health needing to be reasonably well managed. Whatever exactly that means. In standards of care 8, it changed to saying basically that it's just that an individual needs to understand the risks of proceeding with medical affirmation in the context of complex mental health difficulties. Because as we saw from those earlier slides and from what Nick spoke to as well, you know, the mental health experiences and prevalence of psychological disorders in the trans population is immense. Diagnosis. So the standards of care do say that we need to reach a diagnosis. I think as I hope as an industry or psychologists working in the gender space are moving more towards gender incongruence, which is a more depathologizing diagnosis or label than is gender dysphoria. So, you know, you certainly can bring about both diagnoses, but I think gender incongruence is much more depathologizing. As with any diagnostic process in psychology, we do have to go through a differential diagnostic process. I'll talk about that a bit more in the next slide. But also, you know, not just talking about the pathology of it all and the, you know, the negatives of it, but also exploring as someone, you know, gender euphoria and coming from a positive psychology approach around that as well is really important. We don't want it to all be doom and gloom. We want to know about, you know, the whole roundness of a person's experience. We're going to explore the gender affirming medical or surgical treatment that's being sought. So, you know, any assessing mental health clinician in this space really should know, you know, the ins and outs of, at the very least, what the client should know, and in my opinion, more as well. And this is the basis of informed consent. So obviously we have discussions around their understanding of whatever the intervention, what the impact of the intervention is going to be it surgery, be it hormones. If someone's under the age of 18, this is really a key part or a key element of how we start to determine whether someone is GILIC competent. So, you know, GILIC competence really is about whether somebody can understand, hold the information about the treatment, whether they can understand alternate treatments as well. And that kind of forms the basis of where we make that determination. Also exploring people's expectations. So we know in the research that expectations of the medical intervention are linked to the outcomes from a psychological perspective. So making sure that an individual has realistic expectations about what the intervention is going to do, to make sure that if there needs to be some psychological work around modifying those expectations, that's done. Fertility counselling. So we do need to provide a discussion of the impacts of the intervention on fertility, discussions of preservation and support towards preservation if that's needed. And then some standardized measures. So, the WPATH Standards of Care version 8 do say that standardized measures are not needed as a routine part of the assessment. However, you'd probably find that, most diagnosticians in psychology would want to help confirm or support their diagnoses through the use of standardized measures. So these are kind of the main components and the main things that we would explore in a typical WPATH assessment. So differential diagnostic considerations, as I said before, we do have to reach a diagnosis of gender incongruence and or gender dysphoria. Now, this is a tricky space, I think, because when we take a gender affirming approach, we inherently are trusting the client. We're inherently believing the client in terms of their experience and that they know their experience. And I inherently believe that. The tricky thing to navigate here is that WPATH standards of care do say as one of the criteria that a differential diagnostic process has to happen. And they outline these disorders in specifically that we need to, I guess, make sure aren't there in place of gender incongruence or gender dysphoria. What I'll say at the start of this is to really highlight that these disorders are most likely, usually always, as well as, not instead of. So they are usually comorbid rather than differential. And it's really important that we keep that in mind and don't question as part of the assessment process an individual's gender identity simply because of the presence of another disorder. And there really is no evidence demonstrating that there is a benefit in withholding medical affirmation simply due to the presence of a mental health condition or a neurodivergence. I won't go too much into these, but there is a differential process or at least a screening process that does occur as part of the WPATH assessment where it's indicated. So, for example, a personality disorder like borderline personality disorder, I wouldn't necessarily routinely screen for that. It's something that you would, I guess, get a hint of or be able to see usually in the clinical space and during the assessment. Same with psychotic disorders and significant dissociative disorders as well. So it's not that necessarily we're screening everybody for all of these. If it's indicated, of course we do, but we're just keeping a kind of clinical antenna open to notice these. But as I said, they are more likely comorbid than they will ever be differential. And it's just a tricky space to sit into, I guess, have to hold these questions in mind because that's what WPATH say. So, WPATH assessments do get a bad rap, and they, particularly in the trans community, they are often seen as gatekeeping. And that's, I guess I would say, that's a real argument in some instances, that there's a small population of individuals who need a little bit of extra support or a little bit of extra time and exploration in before making their medical decisions. And in order to find those individuals and make sure that they get the support that could be important for them, it does mean that many people are funneled through the process. As I said before, the perceptions of needing to prove transness or prove one's wellness, and there's often this balance that clients will come in with feeling like they need to prove how dysphoric they are in order to be allowed to access treatment, but also not wanting to appear too unwell because they worry that will then disqualify them from medical intervention. The research is demonstrating that there might be little consistency between assessors. So it might be that two different WPATH assessments can look quite dissimilar. Obvious ideological considerations around certain interventions. So, for example, surgical procedures for trans women, a breast augmentation versus a breast augmentation for a cis woman. A trans woman will be put through a WPATH assessment, whereas a cis woman wouldn't be. Access to services. I'm sure we're all very aware of the extensive wait times in the public services, but then of course costs for private services and surgeons as well. Some considerations around, the WPATH standards of care, the criteria. There's a criteria around, I guess, medical appropriateness to proceed with medical affirmation, and also the fertility criteria as well. That these are all kind of being assessed by one person, a mental health professional. It's certainly not, within my remit to make comment on someone's medical appropriateness to proceed. And also, I'm not a fertility counsellor. I know more about fertility simply because I work in this area, but I'm not necessarily a fertility counsellor yet. The criteria, I need to assess that as part of my work. Obviously, the financial burden, it adds an extra cost to what is already often an expensive process, particularly when we're talking surgery. And fears around litigation, which is usually related to discourse around regret and detransition, and which the irony is the rates of regret and detransition are so incredibly low in this space. So into the future, what we hope to see in this space is decreasing barriers to access, and more consistency and standardization within the actual process of WPATH assessments. So whether that involves more standardized training, or particularly from a gender affirming approach. Broader training and education of healthcare professionals, such as in instances like this and tonight, which is really wonderful. Improved understanding, and hopefully in incorporation of lived experience within WPATH assessments. Increase in research, particularly longitudinal. I think so many of the socio-political issues that we have in this space will be debunked once we have a more solid research base that we can demonstrate. Changes to process and access for individuals under the age of 18. So I know that up in Queensland now, GILIC competence, there's been a recent ruling that GILIC competence trumps parental consent. So down here in Victoria, both legal guardians need to sign off. But up in Queensland, if the young person is deemed to be GILIC competent through an assessment such as this, then they can access it without parental consent. And improved collaboration between private sector healthcare professionals. So, if a young person, for example, ends up at Royal Children's, or an adult ends up at Monash Gender Service, then they kind of get all of their healthcare professionals under the one roof in a really kind of connected, multidisciplinary way. And in the private sector, it'd be wonderful if we could be more focused, I think, on that as well, where we're just a team under different roofs. That's all from me. I'll stop sharing and throw to Helene for any questions that have come through. Well, I think you're on mute, Helene.
Sorry, I pressed the wrong button. Hi, everyone. No questions as of yet, but please, we do have time. So pop any questions you have in the chat or question and answer box, and we can get David or Nick to answer them for you. In the meantime, I will throw to Nick or David if they've got any comments before while we're waiting for the questions to come in.
Well, maybe just quickly, one thing that Nick and I were speaking about that we were hoping to cram a little bit more information in, but an hour is only an hour, was around, I guess, the GILIC competence assessment under the age of 18. Other than WPATH, how would GILIC competence be assessed? Yeah. Well, from I guess I'll speak from a psychological point of view. It would be part of the WPATH assessment. And often I find it's actually a process of, I hate this word assessment, WPATH assessment. It's a process of support. So if a young person, isn't really able to demonstrate that they are GILIC competent through the process, and I actually see it as partly our responsibility as the psychologist to see if we can't help them get there. to see what the barriers to that are. If it is kind of cognitive maturity, that's one thing. But if it's more about access to resources and understanding and opportunities to have discussions with a broad set of healthcare professionals, then I see that as part of our role. And what we're looking at is kind of their maturity, their ability to hold the information and provide the information, that the information for them is coming from reputable sources, that they're able to think about the future as well, and even entertain the idea that decisions that we make today might not feel like the right decision for us tomorrow, and having a level of maturity to be able to explore what that might be like for them and how they might cope.
Thanks.
Sorry, I do have one question. So in Victoria, in a person under 18, you need both Gillick competence and parental consent?
Yes.
That's correct. Yes.
No other questions.
I was just going to say, from a general practice perspective around Gillick competence, David's covered it really, really well there in a short space of time. But questions of Gillick competence arise in all sorts of other domains as well, and GPs often make that sort of assessment whether it's in relation to other medical treatments or contraception or a variety of contexts. Yes, this is a little different, but the principles are the same. And it's, as David said, it's around the person having demonstrating a clear understanding of the options open to them and the potential pros and cons and implications of treatment or not treatment, and being able to retain that information over a period of time, and to consider alternatives, and to consider what future implications might flow from whichever decision they make. And those are things which I think, David, from a psychologist perspective, please add. But I think in many situations, GPs are able to make that assessment and do so on a regular basis in other contexts. Yes, sometimes it could be rather more complex, where I guess your assessment is less clear, and there may be may need to seek additional assessment from somebody like a clinical psychologist. But in a lot of instances, it's probably well within the bounds of GP's usual daily practice to make those sort of assessments.
I think too, just further that, the thing that I notice is almost the irony of when a young person, we're wanting them to be flexible in their thinking, to be able to think about a future, different perspectives in the future. When there's almost like that, they might come in with the hard sell that they need to prove that they'll never regret this, that this is absolutely the perfect decision for them. And in my mind, I'm like, oh, let's just be flexible. Let's just talk about the idea that potentially, this might be something that doesn't always feel right for you for the rest of your life. So it's that, because there's no right or wrong. There's kind of the flexibility that we're looking for. Jessica, is there a capacity for negotiation around the need for both parents to consent? Not from, well, no, I don't believe so. It would have to go to family court.
Yes, even if one parent is estranged and lives on the other side of the world, the legal requirement is still for them to provide consent.
Yeah. David, can you talk a bit more about the implications of comorbid mental health? I'm thinking of the complex ones such as DID and psychosis. How do you case conceptualize and consider therapeutic approach in these situations? Do you support concurrent gender affirmation treatment or focus primarily on the comorbid? Sorry for the long question, no worries. Look, as I said, it's from our perspective and what the research demonstrates, as a science-led practitioner, is that it is usually comorbid, rather than differential. It is much more common that you've got the these two things, or usually more than two things, to be honest, multiple things going on. So I would come at it from, I guess, all directions. It would be a concurrent approach. Usually I would do my due diligence and make sure that there was a confirmed, that I could confirm gender incongruence or gender dysphoria as its own existence. That's pretty easy to do, pretty simple. One thing that, one of the little tricks I think of being able to confirm a diagnosis, particularly of gender dysphoria, is when you find the presence of gender euphoria. That really helps to, if it was never gender dysphoria, then some sort of social affirmation or change in pronouns or change in gender expression or change in name shouldn't create gender euphoria. But if it does, then it kind of confirms your diagnosis of gender dysphoria. So I would be working concurrently with that, because also what we often find is when we can get some decreases in someone's gender dysphoria and they can feel more congruent within themselves and their experienced gender, the rest of their mental health tends to at least settle a little bit more as well, because there can be such a profound inescapable experience of distress, living in a body or in a gender that is incongruent with who you actually are. That is something that you're carrying around all day, every day. It is the vessel that you're existing in. So I find that by supporting the gender dysphoria and treating the gender dysphoria, the rest of the mental health, not completely, but tends to have a positive impact on that as well. Hope that helps.
Okay. I don't think there's any other questions, so I think we're right on time to finish. I'd just like to take this opportunity to thank David and Nick so much for a great session, great information. And please don't forget to fill your evaluation out. And also, if you've got any further comments or questions or anything, you can email me at the PHN, and I can certainly pass your details on to Nick or David for further conversation. So don't hesitate to do that. Any further comments from Nick or David?
No, please feel free to reach out. Always happy to chat. Yeah.
Thank you. And thank you all for attending. See you at the next one. Bye.